Good afternoon and welcome to the Washington Institute. I'm Rob Satloff. I'm the director of the Institute. And I'm very happy to host today's very special policy forum on health politics and stability in the Middle East. Just today, I saw a World Food Program report out of Cairo, which showed that there was a 19% increase in COVID-19 cases throughout the Middle East in just the last 2 weeks, 44% increase in just the last month. And as the Eid al-Adha feast approaches this weekend, people around the region are focused not on celebration, but on this dire new reality. To discuss how governments and peoples around the Middle East, and especially in two of the region's most critical countries, are focused on the challenge of COVID-19. I'm delighted to welcome this panel of real specialists to provide insight and expertise to help us understand precisely what is going on in this region and what governments and peoples are facing. They come from three different places. Let me just introduce them briefly, and then I'll turn to them to offer some opening remarks. Let me say right at the outset that I encourage everyone who's viewing this program to send questions for our speakers directly to me, Rob Satloff, rsatloff @washingtoninstitute.org, and I'll be able to funnel them into our discussion later in our question and answer session. So our panelists today are Dr. Ali Mokdad, a former senior official of the Centers for Disease Control and Prevention. He is currently the director of Middle Eastern Initiatives and a professor of global health at the University of Washington's Institute for Health Metrics and Evaluation, and a specialist focusing, of course, on the situation of COVID-19 throughout the Middle East. Then we will hear from Dr. Mohammed Hassan Khalil. Dr. Khalil is a retired cardiologist who's calling in from Cairo, and he's founder and chairman of the Committee for the Defense of the People's Right to Health. I'm delighted that he can join us all the way from Egypt for today's discussion. And then calling in from Boston, Cambridge to be more precise, Dr. Mohammed al-Maliki, also a practicing cardiologist, a research fellow at Harvard University's Weatherhead Center for International Affairs, focusing on the intersection of politics and health. Also the director of the Iraqi American Institute will provide us insight and expertise on the situation in his native country. So we're going to begin with Dr. Mokdad for an overview. Dr. Mokdad, the floor is yours.
Thank you, Rob, and thank you for having us. And I want to briefly talk about IHME, where my institution, Institute for Health Metrics and Evaluation, we monitor the health problems of a location, every country. We monitor what the countries are doing, what the society is doing to address them. And the third one, the most important one, is how could we maximize our input, given what we have as input. And we've been doing a lot of projects in the Middle East, including the global burden of disease. We do future health scenarios where we show, like diabetes, how much it will be in 2040 in Egypt, with what if scenarios. For example, if you reduce obesity, what will happen? We monitor the sustainable development goals, and we monitor all the financing for health financing in the world. All our modeling for COVID-19 started at the request of our university medical center because they wanted to prepare for the surge. They wanted to know how many ICUs they need, how many beds, how many ventilators. And we started doing this modeling for our own institute. Then we started doing it for other hospitals and for every country, a lot of locations, states in the US, and now we're doing counties. Our early model started following mortality because we didn't have enough testing early on to do what we do in infectious disease modeling, which is susceptible, exposed, infected, and removed. And then as we got more data, we improved on our modeling, and now we have data on mobility, mask wearing, testing at every location that we can use in our models. The issues we face and what we do in terms of projecting the COVID burden between now and we have it until January 1st is in many countries there is underreporting of mortality due to lack of proper vital registration systems, or intentionally in some cases. And also because of lack of testing and the ability to do enough testing. And testing in reality, especially in the Middle East, is expensive. It costs about $10 to $20 per test. So if you're a country like Egypt doing 10,000 tests a day, that's very expensive, or Pakistan. Before we started getting into the projection for COVID-19 in the Middle East, we all know the Middle East, the wars, the poverty, the conflicts. And then we have major religious sites in the Middle East, in Saudi Arabia and Iran and in Iraq. And we have, unfortunately, in all countries in the Middle East, no exception, poor public health infrastructure. And in some countries in the Middle East, we have good medical systems, private, and very rarely, sometimes it's a government. So what happened in the Middle East as COVID-19 started rolling a pandemic from China, many countries in the Middle East, all of them locked down in March. So what you have in the Middle East is countries that did have less seeding, less circulation of the virus when they locked down, didn't see a rise and increase in COVID-19, and they felt there is a false sense of security. So they started relaxing and opening right now. There are exceptions to that. Iran had an event, which is a sporting event where people came from China, even from Wuhan in January, and started the spread of the virus. Iraq has a religious site. Iran has a religious site and started spreading. Of course, Saudi Arabia and Egypt has a major tourism industry that people came from Europe and spread the virus. So these countries were at the worst position when they locked down. So you see that rise in infection in Iran compared to a country like Jordan, where you don't see any COVID right now because they're able to control it. And when they lock down, it helped them. Now, as you relax and open up, and the countries in the Middle East face several challenges, and they are between two hard decisions. If they don't open up and roll back their economy, they will suffer a lot of long-term health effects, malnutrition, etc. So, and if they open up, there is an issue of overwhelming their hospitals and an issue of increasing mortality from COVID-19. And that's a very hard decision. I don't envy any politicians in the Middle East right now or any minister of health in the Middle East. Our projections for the regions, for Iran, we project about 52,000 deaths right now. Iraq, about 14,000 deaths between now and November 1st. Egypt, about 11,000, and Pakistan, about 10,500. What I'd like to end by saying, with reduction in oil prices right now, what we are concerned about the Middle East and the large vulnerable population, whether poor in every country or in some countries foreign laborers that are not now infected the most by COVID-19 and not able to go back to their countries, in the Gulf, for example. So that's a major concern for us, that there'll be more infections on the long run with this second wave or the continuing of this wave. And we'll have a setback on health gains that were achieved by some countries in the Middle East against all odds, for example, in addition to the conflict that's going on. I'm concerned in the Middle East in terms of stability as well, not only the health effect on the long term, but stabilities, because that will impact the economy, that will impact riot, it will impact demonstrations, and we are very much concerned about that. It's a vicious cycle in the Middle East, unfortunately, where poverty will lead to unrest, and unrest will lead to poverty. So we have to be very careful. As for COVID-19, some countries are doing a good job in containing the virus. They're being very transparent in what they are reporting, how many tests they are doing, where the tests are being done, how much people are dying from it. But in the Middle East, many countries are not reporting that. And we are switching right now at IHME in order to monitor excess mortality rather than what is reported mortality from the countries, based on some modeling. And eventually, unfortunately, for a disease like COVID-19, the truth will come up again, because we know from the next census or the next survey how many people died, and that will come up maybe a little bit delayed. Unfortunately, countries need to be more transparent and releasing these numbers so we are able to monitor the virus and we are able to take the right policies based on right data. Otherwise, we are going to miss the boat. I'll end up here, and thank you very much again for having.
Thank you very much, Dr. Mokdad. Just before we turn to Dr. Khalil, can I ask you, can I put you on the spot? Could you tell our viewers the 3 countries who are most transparent in your view, and the 3 countries that have been the least transparent in your view?
They have been transparent because they don't have much COVID-19. So let's be careful. Jordan has been very transparent, has done a wonderful job of containing the virus. Even in one of the outbreaks that was imported, they used the army, and the army in Jordan is more trusted than the police. So they've done a good job. Lebanon has been so far transparent, releasing the number of cases and the number of hospitalization. And Tunisia has been doing a good job releasing everything on time. The countries that we are afraid are not releasing on purpose or not their ability to release the data. Egypt has the infrastructure to release the numbers. I suspect that the reported cases of deaths in Egypt are underreported. We suspect that. I may be wrong. And Saudi Arabia is underreporting, in my own opinion. Iraq, of course, combination of underreporting and combination of not a proper vital registration system to capture what's happening. And to my surprise, the Iranians have been reporting for now, and I don't know if this will last. Thank you.
Well, thank you very much. So it's appropriate that we have specialists from at least 2 of the 3 countries that you suggest may be underreporting for one reason or another. And so I'm going to turn now to Dr. Mohammed Hassan Khalil in Cairo to offer your look at what is going on in your country of Egypt. Dr. Khalil.
Thank you very much, Rob, and thanks for the Washington Institute for hosting me in this session. In fact, I totally agree with Dr. Mokdad's general conclusions that he made about our area and also about the lack of transparency. And I'd like to share with you some of the detailed idea about the real situation of COVID-19 in Egypt and the long and short-term challenges we face. In fact, the Egyptian population is now about 100 million. First cases of COVID-19 in Egypt were recorded in March 2020, and officially announced total cases affected till today are about 93,000, and total deaths about 4,700. But before continuing, it's important to notice that the total number of cases is the number of only positive PCR cases. While this is the investigation is in fact not performed to all suspected cases. Suspected cases are divided into 3 categories. For mild and moderate cases, the advice is home restriction without PCR, even if the CT, chest, and all ordinary investigations highly suggest that they are really diseased. Of course, you can say, so long as we do not do the tests to all highly suspected patients, we also do not make public screening to identify the hotspots and to identify the real prevalence of the disease in our country. Nor do we take swabs to do PCR from the dead, even if they died with COVID-19, as it's highly suspected. This is one of the major disadvantages of governmental policy in dealing with the pandemic. As regards the official numbers announced, Egypt occupies the 30th of the world among 220 countries. Yet, as regards the percentage of investigation to the total population, in Egypt, it's only 0.13% of the population, ranking 166 country among 220 countries in the world. In advanced countries, we usually see the average rate of deaths is between 5 and 10% of the population. Of course, in many countries are more than that. And in the moderate income countries like Egypt, it's between 5 and 10%. But as I mentioned, in Egypt, it's only 0.13%. Of course, this shows to what under extent the fact that our friend said there is lack of transparency and huge underestimation of the real number. Yet the real number announced now is 100,000, which means that we have 1 per thousand of the population, and if the total number is probably 5 to 10% doubles of that, you can imagine the real extent of the spread of the virus. The governmental response to the pandemic in its primary stage was in general adequate, with the necessary measures of social distancing and closure of places of gathering like schools, cinemas, clubs, coffees, etc., together with caring with personal and public sterilization procedures. Suspected cases at that time were all hospitalized for isolation. Yet, according to the WHO, the problem arises in countries with fragile health systems, especially when the pandemic is spread on a larger scale. This usually takes place when the disease spreads and the cases increase. Egypt is not an exception, though it has its peculiarity. In early 60s of the last century, the WHO considered the Egyptian health system is a real revolution in the third world when it succeeded in building an advanced health system and infrastructure, providing each city with a local hospital and a rural health unit in about 40% of the villages, and offering a complementary health system which provides primary, secondary, and tertiary health systems that offers the citizens with adequate health services available to all citizens in an affordable way. Starting from mid-70s, the government starts what's known as the open door policies that concentrated upon austerity measures, including decreasing resources allocated to health among other services, and the gradual withdrawal of the state from both productive and domestic services. Budget allocated to this sector went down up to 1.7% of the total governmental expenditure in some years, which is equal to about 0.5 of the GDP to be expended on health. Of course, as we may expect, that this has caused marked gradual deterioration to the health infrastructure since then. The World Bank, IMF, and USAID suggest privatization as a reform for the system. To give an idea about how the Egyptian health infrastructure deteriorated, we have to notice that between 2008 and 2019, the governmental hospital beds decreased by 25%, with mild increase in private hospital beds, far from fulfilling people's needs, needless to say, with the lack of affordability. The governmental health services were also compromised by the decrease in health expenditure. The following rapid indicators show the extent of this problem. The governmental beds went down to 1.2 bed per thousand population. It was 2.2 in the census, and the world average is 2.9 beds per thousand population. The number of available doctors is now in Egypt 1.2 doctor per thousand citizens, which means that this is only 40% of the adequate needs. The adequate needs is 3 doctors per thousand. And we are not speaking about advanced countries who have 6 to 10 doctors per thousand population. Of course, the same is true as regards the nurses. To notice here that there are 120,000 Egyptian doctors working domestically, while there are 100,000 Egyptian doctors now working abroad, whether in the Gulf area or in Western countries, West Europe and USA, either on permanent migration basis or temporary migration for some years to collect money. Also, as regards the point our friend talked to us about the availability of intensive care beds, in fact, in Egypt, we have only 10,300 ICU beds, both private and public sector.
Dr. Khalil, so we lost you for a moment.
Sorry for this technical problem.
So,
yes.
Can you just sort of wrap up your remarks?
Yes, I've been concluding. Finally, I think the real question that faces Egypt is not different from that faces the whole world. In the short term, the problem that both the world and Egypt faces in the contradiction between the quick restoration, the need for quick restoration of ordinary life for economic constraints and the health needs of prolonging restrictive measures. Yet, with the WHO in that respect, I agree that we should weigh the danger of rapid opening with its consequent escalation of cases. In the future, I think the main challenge that faces Egypt is also the same one that faces the world, which is about allocating the appropriate budget for the important things, which is people's health, and for building the health system to cope with the ordinary needs and the emergency needs of health to people in both an equitable and affordable services available to all citizens. Thank you.
Thank you very much, Dr. Hassan, Dr. Khalil. Okay, Dr. Al-Maliki on Iraq, the floor is yours.
Okay, well, I would like to thank you, Rob, and thank the other panelists for their talks as well. So this, my portion will focus on Iraq. Is a country that is known to be challenged in multiple dimensions. I have organized my talk to cover 4 points. I will begin with the numbers, then I will state the chronology of the situation, offer an explanation why, and then detail some progress in handling the spread of the disease, and then I will conclude. We'll begin with the numbers. Iraq stand at, as of yesterday, I did not update the number today, at 12,585 cases, of whom 4,485 have died. And that is about 4.1% or so. Iraq has conducted about close to 1 million tests so far. The daily death is up to 100 in these days, and the daily reported cases average about 2,500 per day. Now, in putting these numbers in context, so Iraq is the third Arab country, the third in the Arab League countries with regard to numbers after Qatar and Saudi Arabia. And we have to offer an explanation why that is. Of course, we'll discuss a little later the false negativity of the results and of the statistics in Iraq, and followed by Egypt. It's the second, with regard to mortality, is the second country in the Arab League after Egypt, followed by Saudi Arabia and Algeria. And it is the 23rd in the world with regard to crude statistics without relating it to the population. Once you divide that number by the total number of population, Iraq engages position number 39. And it is worthy noting that when you relate the cases to the total number of population, the Gulf states are in the top 20 countries among the 211 countries affected by the virus in the world, Qatar and Bahrain being number 1 and 2. Now, the evolution of the Iraqi story. The first case detected in Iraq was in February 24th and was thought to have come from Iran. Iran at that point had recorded thousands of cases, I think started in January from China. The response, like it was in Egypt, was adequate. A curfew was imposed. Schools, mosques, public gathering places were closed. Attendance in the religious sites were also curbed. So that resulted in an acceptable trend in the first few weeks of the crisis. And by March 22nd, a nationwide lockdown was first introduced. So good results. Iraq kept the cases under 100 per day from February 24th all the way until mid-May. Mid-May happened to be Eid al-Fitr, the end of Ramadan, where people took liberty attending gathering. And in June 1st, the WHO issued warning that it has spotted mass gathering in Iraq everywhere for social, cultural, or religious reasons. And indeed, the first spike happened between the 3rd and the 5th of March, where cases increased to about 1,000 per day. Just to give you an idea about the size of the jump, in mid-May, the total cases reported in Iraq was only 3,200. And it jumped to 36,700 on June 24th, about 10 folds in 5 weeks. And not only that people took liberty in loosening the restriction out of themselves, but the government became relaxed as well. In fact, they decided to partially lift the curfew on June 14th, even though the trend was uprising, and there was a plan to end the curfew by Eid al-Adha. This was coming in early August. Now the situation has, of course, changed. A sad event that alerted the Iraqis to the magnitude of this problem is the death of a football star, Ahmed Radhi, on the 21st of June. He is an Iraqi legend. He's the only Iraqi player who scored in the only participation of Iraq in World Cup in Mexico back in the 80s. And in fact, if you saw the details of his death, it gave you an idea how Iraqi health facilities handled the situation then. He appeared in one video talking to the reporters that he was doing well. A few hours later, in that same room, he was reported to have died, which sort of give you an idea about how these health facilities handled and triage these cases. Now, I will mention something about the reporting and inaccuracy of these numbers. So it's a common understanding that the true cases in Iraq exceed the reported by many, many folds. In my own experience, I have been tracking not officially these numbers, but through anecdotes, because I've been helping Iraqis through some WhatsApp contact, helping them with non-COVID and also COVID cases, advising, prescribing in a sort of a telemedicine platform since the crisis erupted. And I have gotten many, many stories of people staying home, not going to be tested, either because the testing capacity is not there to meet the demand. And also people are afraid of going to any health facility, fearing that even if they don't have the virus, they will capture it during the testing process. So the current cases that I mentioned, 2,500 per day, actually does not reflect the true number. It basically reflects the testing capacity of Iraq, because these are the numbers that are reported after resulting positive. And there's some report that indicate that about 30% of tests are false negative. And there is a testing problem besides the quantity being limited, but the testing quality is also inadequate, meaning either the swabbing is erroneously done. There's a problem with the proper transport from the testing site to the processing site. There's a problem with the devices that process these samples. So this kind of bring the false negativity up and bring the true numbers of cases down. Now, with the deaths, so Iraq has reported a little more than 4,000, and indeed, some reports from doctors have been interviewed, they've been signing about 25 death certificates per day for people who have died at home. Most of them were thought to be due to COVID-19, and people who may have died of COVID, but they have history of other conditions, the death was attributed to the other condition, not to COVID. So these factors combined gives you an idea that perhaps the number of cases and death in Iraq are a lot higher than what we know. Now, why that is? A couple of points on the health infrastructure. So COVID is another crisis superimposed on many other ongoing crises in a country that is too weak to be able to accommodate. There's ongoing security and ongoing financial and economic crisis due to the fall in oil prices. Health is also a part of a universal infrastructural problem. Health is a final output of a series of direct and indirect inputs, such as security, education, water, electricity, planning, finance, regulation, and there is a severe lack, or all these sectors are weakened by the repeated traumas and conflict that started perhaps in 2003, you can say 1991, go back to 1980 even. So the COVID-19 crisis in Iraq is coming onto a system that is already stressed, under-resourced and understaffed. In fact, the Ministry of Health receives only 2.5% of the budget that has already been impacted by the oil prices fall. Just to give you an idea about some health indicators to tell you where Iraq is before COVID crisis hit. Iraq's ranked with regard to the health indicators among the low-income countries. Maternal mortality, 50 per 100,000 deliveries. Infant mortality rate, 22 per 1,000. Below 5-year mortality rate, 35. Vaccination rate, 61. These are considered the most sensitive indicators to give you an idea where the health system, how the health system is functioning. Now, how did the government handle and why did we actually reach the crisis level? Is simply poor handling. Besides other religious and cultural and social factors that made Iraqis loosen the restrictions. So first is debilitated medical infrastructure. These hospitals and health facilities, to start with, had very poor conditions. Poor infection control, there's a lack of PPEs in the beginning and insufficient isolation measures. There's poor triaging and prioritizing of cases, meaning mild cases who do not have hypoxia get admitted, occupying the beds that should have gone to the severe cases. While most of the world have decided not to care for cold, non-urgent cases until the COVID diminishes or slows down, Iraq continued to care for non-COVID, non-emergent cases, mixing them in the same hospital, the same facility with COVID patient, enhancing more spread and diverting resources that are needed. There's a testing problem that I have already explained. And another notable observation is the high infectious rate among staff. The Iraqi Medical Association report, which is a number I don't believe, like 83% of their junior doctors have contracted the virus. The number is 592. The 592 I believe, but the 83 perhaps either an error or something exaggerated. However, Iraq has become notorious of not offering protection for the medical staff. The rate is 6.6% of all cases have affected health providers, doctors, nurses, and other hospital staff. The other thing in Iraq is this reliance on the treatment rumors. So I call it Facebook therapies. There are a couple of Iraqi surgeons came on Facebook channels to say, I have invented this therapy and I tried it on 30 patients and I cured them all. Another doctor said, well, I have tried lidocaine, local lidocaine on the mucous membrane of the throat and I have amazing results. And people start believing and circulating this information. Another lady said that if you cover onion with a sheet of clothes and you inhale it, you can actually get some results. And people out of desperation, they started believing some of these measures and circulating them. The other thing that I have just was on the phone with my niece, who is a junior doctor at the Port Hospital in Basra, and she works in the emergency room. She said the treatment protocols are the protocols that the world has abandoned about 2 months ago. They're still using the hydroxychloroquine, the azithromycin. They are using immunomodulators that only under clinical trials here in the US, I don't know how they get access to them. They are using combination antiviral agents, not the remdesivir, but the other ones that have been proven to be either toxic or not effective in the US. And it is done in a haphazard way, meaning it's up to the doctor or up to this emergency room, up to the ward, up to so and so. The other thing is the lack of any level of intensive care. We know that about 80% of COVID cases, they resolve on their own by simply home care. The percentage that deserve to be cared for in a health facility is about 20%. And those people tend to be higher age with comorbidities and whatever. And depending on the country health system, the mortality usually among these 20% indicate the efficacy of the health systems. So perhaps Iraq high mortality indicate that is basically everybody who is in moderate, severe, or critical end up not doing well. I don't need to even elaborate on the economic and social impact. Is obvious, and I alluded to under the financial. I will conclude by saying the following problem needs to be addressed in Iraq. The growth is exponential and it's really going at an alarming rate, and there is no indication that is slowing or stopping. That statistic is incomplete and falsely reported. My niece told me that we don't rely on PCR to verify whether the patient has died of COVID. We rely on CAT scan because this is how unreliable testing in Iraq has become. And usually the test result comes a week, 3 days to a week later. It has to be sent to a central processing facility. Testing problem, poor infectious control, poor hospital regulation, high infection among health workers, and if they get depleted, who knows where we can get the human resources to care for the next wave and financial crisis. There's some progress. The ministry has issued new guidelines. They have dedicated a new hospital for COVID, or new wards within the hospital for COVID. There is some progress, but it's still a lot lacking and a lot needs to be done. Thank you.
All right, thank you very much. Thank you to all of you. Let me remind our viewers, if you have questions, please feel free to contact me directly at rsatloff@washingtoninstitute.org. So let me begin, if I can come back to Dr. Mokdad. First, you focused on a indicator you thought in the end would be the most useful. You referred to excess mortality. Is there any way that we have any data yet that give you some insights based on a focus on excess mortality that might clarify some of the grayness that we've heard from your colleagues regarding Iraq and Egypt?
Yes, we have some data. So I was fortunate when I was at CDC, I trained a lot of people in Iraq, Saudi Arabia, Egypt, part of the field epi training program. And I work closely with these ministries of health on a regular basis. We get data from them. So right now what we have is not reported official. We have hospitals data. So we have some hospitals that are telling us around this time, this is what was the mortality rate in my own hospital. So again, these are people who are coming to the hospital, so you're not getting the full picture. Many people are dying outside the hospitals and our part of the world. But for countries where death occurs in the hospital, in Lebanon and Jordan, every death ends up in a hospital, especially in summer. They come to the hospital and then they go to burial. So we have reports even from Yemen, from Aden. We have reports from hospitals where we see an increase in mortality around the same time. So we have an idea. That's why when I say Egypt, Saudi Arabia, and Iraq have underreported mortality, we have some of this data that will help us to do so.
And when and with the estimates, the projections that you gave in your remarks about a likely mortality in some of these major countries, when you focus on the variables, what could change that between now and say the end of the year?
So very good question, Rob. What I'm projecting right now is the officially reported numbers. Because if I report the excess mortality, a country like Egypt, I'm not picking on Egypt, will say, oh, you're saying 50,000 deaths, but we only have 4,000 right now. So what are you talking about? So what's predicting mortality in every country in the world is density of the population, which we have very high density in many parts of the world, how many people live in a household. Testing, percent positive of testing. Mobility, mask wearing, and we have data on mobility and mask wearing and safe distancing from Google surveys and Facebook surveys. Again, these are the affluent people in the Arab world, so in the region. I mean, Israel, Lebanon is not a problem, but in other parts of the world, this is the affluent population. So we have that data. And COVID-19 is following pneumonia seasonality. So it's coming down now in our region. It will go up in fall and spring, fall and winter. So these are the variables that are predicting mortality right now in our models. And then we're working with ministries of health to update the number of, if they had a surge in their hospital capacity, so we can use these numbers to update our projections.
Okay, thank you. Dr. Hassan, I have a questioner who sent in a question who asks this. Even given all the infrastructure issues and health system problems that you identified, over the last several weeks, this questioner says, Egypt has recorded 3 straight weeks of reduced numbers of cases, going from about 1,500 to about 500 per week. What explains this? If you think that these numbers are themselves accurate, of course, that could be itself a major explanation. So,
in fact, in analyzing statistics, we used to do something in Egypt and such countries with lacking of transparency, is to correlate statistics with political reasons. And now Egypt has been preparing from some time that we are going to live with the disease like other worlds. We are going to open up, and we're not going anymore to continue restrictions of gathering, etc. And here we notice something very strange. As we have made the restrictions much less, the rate of infections goes down. Do you think that this synchronization is true? And tell you something, we have some indicators by our knowledge and contact, which is patients do not find hospital beds. Patients who need hospital beds by the very restricted rules of the government do not find. Some can find beds after 2 or 3 days in distant hospitals, hundreds of kilometers from the city where they live, even if this city is Cairo. As you see, the government, the Ministry of Health, usually daily says there are available beds, no shortage at all. This is catastrophic. Also, as regards to the medical team, the Egyptian Medical Syndicate has an accurate census of at least 90% of doctors who die of the disease, because it gives a compensation. So most doctors go to or relatives of deceased doctors go to have this compensation. The percentage is incredible. It's more than 3% of the total deaths of all cases announced by the government. From that, you can see that we have a huge underestimation. And me personally, I don't believe the number of 500 is near from true.
Okay, thank you. Dr. Mokdad?
So this is a pattern we are noticing in many countries in the region. Let me explain it from an epidemiology standpoint. The rates are coming down, that's true in Egypt, Saudi Arabia, and Pakistan. But it's a false sense of security. Let me explain why. So what we are saying, the number is still underreported, but the trend is correct. And let me explain why. What happens in every epidemic and pandemic like this, you will have what we call an epidemiology harvesting effect. So the first wave comes in, people who are very sick and about to die, unfortunately die early from the death. So you see a spike in mortality, then it comes down to a normal pattern. That's one. Two, in both Egypt, Pakistan, and in Saudi Arabia, what happened, those what we call super spreaders, say somebody who's in a market, a pharmacist, taxi driver, has either been infected and removed, deaths, or has immunity for the disease. So that gives you a false sense of security. For a while, it comes down. We've seen it in Iran. It comes down, then it starts reaching to the other segment of the population, then it peaks up again. We've seen it in the United States. My concern is we shouldn't focus on is it right or not. We know there is underestimation. The pattern is correct. We see it. Hospitalization in many parts in that 3 locations is coming down. But the key point here is a false sense of security. It's going to come back again unless we are very careful.
And so here, in all these countries, it seems to me, it then hits the set of political issues. I mean, it's one thing to issue a lockdown to impose restrictions early in a crisis. It's something totally different to say, I made a mistake. I opened too quickly. Leaders in a democracy have a difficult time saying, I made a mistake. It's exponentially more complicated in systems that have, shall we say, a weak democratic infrastructure, to be polite. Do we see this as a phenomenon, how difficult it is to reimpose restrictions? Dr. Al-Maliki, just one second. Dr. Al-Maliki, how are we seeing this playing out, for example, in a new government which just took power in Iraq?
Right. Well, I did not actually see any new initiatives. I mentioned once Prime Minister Kadhimi took office, I said to a group of elites that there are two challenges facing Kadhimi. One is COVID, and the second is the financial crisis due to the. And I have not really seen any aggressive measures. The response to the new surge of cases and deaths in Iraq, the response on his part has been very, very timid. He has been addressing security problem with this sort of random assassination. He's reached out to Saudi Arabia regarding the financial problems, asking for loans here and there. His Ministry of Finance is very active. But I really have not seen him. There are some measures coming from the Ministry of Health, and there is a higher committee of health to address that. He is the head of it, and they meet weekly. But I have not really seen him imposing a new strict curfew to curb the cases. Things are still, let's say, relatively loose compared to what we see. My niece today said that the 2 hospitals in Basra dedicated to COVID cases have been full for weeks, and we only admit a new patient only if somebody is dead, because the cure rate is very low. So the government needs to do more, and I don't see them doing enough.
Dr. Mokdad?
Thank you, Rob. It's not only a premature opening of the economy, which is right. They have a hard time saying I made a mistake. They're opening their airports. And now you look at a country like Lebanon, the importation of cases is becoming a major problem. And when you have high rates in the Gulf and people are going to come to Jordan, now Jordan is so concerned that, hey, they're coming from the Gulf, they're more likely to be infected. So let me give you a specific example in the Middle East, what has happened. Take the Minister of Health in Lebanon. I was in a big hot spot in Lebanon, where I'm originally from. The Minister of Health in Lebanon, because he locked down early, we didn't see COVID-19, it went down. He went to his base where he comes from in Baalbek area, dancing, debki, with no mask. And now we're coming back. So here as a Minister of Health, what could he say? I made a big mistake. What did I tell people to do? What mixed messaging I'm sending? So that's a big problem that we are facing in the Middle East. You're right, Rob. Exactly right.
I may add, Rob, that, sorry, can I interject a little bit? Because I sort of forgot to mention sort of the balance, the delicate balance between medicine and economics with regard to the virus. Iraq also does not have the resources to mitigate the economic difficulties that a big sector of the population is undergoing. Iraq has 2 types of employment, either public employment or informal sector. The public employment has been hit by stoppage of salaries or reduction of salaries because the government does not have money. And the informal sector, no one has really addressed it. We don't have the resources like America has to go and register for unemployment and then get money coming into your mailbox. That is not happening. And the private sector, which is already very, very minimal, also has sort of frozen. So the balance, the necessity to balance economy and the virus is there. And this is a very sensitive, and for Iraq is even more difficult, perhaps.
Look, I should say I approach this issue with great humility here as an American. It's not as though we've done such a great job on any of these issues. So I have humility about the challenge that Middle Eastern governments are facing. But I also understand why, if you are in Egypt and if you are in Iraq or wherever you are, and you're looking at what your government is or isn't doing, I mean, these are life and death matters. And so I appreciate the challenge you're facing. I have a question from one of our viewers who's asking about regional cooperation. Is there cross-border cooperation? What areas could be, in what areas would more cooperation be beneficial? And what areas are there artificial barriers to cooperation that would be beneficial? Are there some aspects which are working better than others, both from your own internal view in Egypt and Iraq, et cetera, and from the more over, the general view? I'll begin first with Dr. Khalil. Do you see any sort of any sort of cooperation that's going on?
Yes, there is a good cooperation with some countries, and China and Russia have sent to Egypt many protective facilities and so. And also there is an important, if you may say, a cooperation, which is our country being heavily populated, and the infection rate is not low. So it's a chance for different inventors of remedies and vaccines to experience it. So we have so many countries experiencing drugs in Egypt, from China to USA.
Interesting. Dr. Mokdad, what's your view on regional cooperation potentials?
So WHO, the regional office of WHO, has been doing a good job coordinating. So, and there is a lot of coordination from doctors in Iraq who are outside, helping doctors inside through WhatsApp. And there have been a lot of joint conferences where physicians from the US have been presenting what has been done here and what kind of treatment. So there is a lot of coordination. Cooperation, no. Let me explain why. Because every country is really under the water. I mean, we have to be they're not able to help each other, but they're able to coordinate and they're able to share knowledge and experience. But like a country like Saudi Arabia giving support, financial or equipment support, we've seen a little of it from some Gulf countries to other countries, but not as much as before, when there was a problem that affected a country, unfortunately, because everybody is struggling at this time.
Mm-hmm. And have we seen all the human flows of migrants and workers? Have we seen those come to a halt over the last 4 months?
Yes, in fact, people are losing jobs in the Gulf and coming back. So we're seeing a reverse right now. And then it's impacting the remittance that people send to their families. So it's impacting economy everywhere. Rob, my concern in the Middle East, and I feel like we need to talk about it here, is protecting hospitals and protecting key businesses in the Middle East. So a country like Iraq, as the doctor is saying, protecting your hospitals, otherwise you lose it. You're overwhelming them and they cannot survive any other wave of COVID-19. Also, your main essential businesses, food production, how you protect that. And right now in the Middle East, because we are chasing and not planning strategically ahead, I'm concerned, like a university where I graduated, American University of Beirut, will face bankruptcy as an institution and the hospital will fail. And then when you have an institution like AUB, it's setting standards in Lebanon and raising the standards in the Middle East. And I'm very concerned about our hospitals, our physicians, our brain in Egypt and Lebanon, that they will go to the Emirates to work instead of working in Lebanon. So that has been a major concern for us, because strategically when we opened up, we didn't open up the businesses that are strategically for the country. In Lebanon, this is the big problem I'm facing. They opened the coffee shops, the bars, and the restaurants. I mean, how could you do that? How could you not protect your hospitals, your business of economy of food production? before you go into the rest. So we haven't been strategic, unfortunately. And the people who are vocal in these countries are in Egypt, the tourism, in Iraq, the religious tourism. They want people to come because that's how they can make money. And you said it, I'm so concerned around the Eid because we've seen a spike from the previous Eid. And this Eid is coming up at a time where we are all relaxing. So we are in a very difficult phase in the Middle East.
Just on that point, both our guests from Egypt and Iraq focused on the danger to health workers, the huge danger to doctors and nurses and people involved in the delivery of healthcare. One assumes that this will have a knock-on effect that will have a very negative impact as we proceed down, future stages of this pandemic. Dr. Al-Maliki?
Yes. Well, yes, indeed. I mean, I don't have the statistics. I have them somewhere. I didn't prepare them. That says about the number of doctors per 100,000 population is relatively low. The U.S. reportedly 4 or 5 times. So there's a sort of standard number by the WHO that recommends each country to have. That is already low. I mean, the quality of medical education has gone down anyway, so that is sort of a factor need to be considered. The staff that is running the COVID hospitals in Iraq are the junior staff. So the young men and women who have just finished medical school in the first 2 years, they are running the emergency rooms and they're running the wards and they are running the ICUs as well, because what we call the attendings here in the US, they call them consultants. They hardly ever come to the hospital. They manage cases over the phone. They don't come and make their rounds fearing infections. My niece was indicating the poor infectious control in the emergency room, one of the Basra hospitals. She said, there's a room about 2 meter by 2 meter, and is trashed with used PPEs around and masks everywhere and whatever. So there is no enough protection for the medical. Those young men and women are the only ones that is sort of staying around, and a few of the little permanent resident, they call them, or permanent doctors who kind of finish their rotating internship and they go into specialty. They are present, but not in high numbers. So it's already strained and already small. And imagine those young doctors get infected, then I don't know how the response will be the next wave. Now, the Ministry of Health is asking dentists and pharmacists and paramedical staff to get some of the training to come to these newly built field hospitals to staff them, because there is no enough doctors or providers to staff these improvised hospitals.
So, Dr. Khalil, you're nodding. I see you nodding as well. Is this a similar phenomenon in Egypt? The not just the general shortage, but the knock-on impact of COVID hitting disproportionately health workers, and how this is likely to impact in the months ahead?
Let me tell you about a problem that exploded very recently, which is the very high percentage of escalation of infection in doctors and medical staff, and the lack of the very, very necessary protective measures for doctors, to the extent that the governmental policy is that if an employee in any area seems to have COVID-19 fever and some symptoms and so, no tests or the ordinary test, and just go for home isolation. As regards doctors, for doctors who have already been mixing with positive cases, they refused to do the test for them. They said, we shall wait for 2 weeks if symptoms come. But they prevented them even from home isolation. So they kept on practicing and infecting patients, which is horrible. And that's why it came some time that infections escalated, and we had more than 100 fatalities among doctors only when the total number of mortalities in Egypt was something around like 3,000. So it's very high percentage. This led to strikes in some places and led to a campaign launched by the Egyptian Medical Syndicate against these measures. And at that time, there has been a campaign of propaganda against doctors and medical staff in the media, in the governmental media in particular. Anyway, this has been ended by a meeting between the chairman of the Egyptian Medical Syndicate and the Prime Minister, not with the Minister of Health, because she made so many problems in this respect, even to accuse doctors by the escalation of number of infections. So it seems that there has been some compromise. It has been noticed that the protective equipment for the doctors in hospitals have been improved about significantly, but in fact it's a real problem. And I totally agree with what both partners in the talk have mentioned.
All right, so look, as we reach the end of our session, let me ask all three of you, because we're speaking largely to an American audience today. If there is something, and it might be a big if there's something that the United States government can and ought to do to assist, either specifically in Egypt and Iraq, or more generally, helping governments around the region address this crisis more effectively, what would you like to see the United States government do? Dr. Mokdad, we'll start with you.
That's a very difficult question, but COVID-19 came on top of a lot of problems in the Middle East, and we're not talking about economy and unrest. The U.S. could help us a lot of, having peace in the Middle East. That's the biggest one, the biggest challenge we have in the Middle East. But let's focus on health here today. It has exposed a weak public health system in the Middle East, all countries, even in the U.S., you and I know that. But it also exposed a vulnerable population in the Middle East that the government have tended to ignore. So poor people in Iraq, poor people in Egypt, what the Gulf calls guest workers, they're more likely to get the disease, and they're essential workers, they'll interact with the locals, and then you'll see a spread in Qatar and Bahrain because of that, because the poor conditions they are. And then also from the medical system, it has exposed our weaknesses. Our governments, our ministers have invested in building hospitals, not in public health. Because in a short term, a physician opening a clinic will look good on the newspapers. And we changed them a lot in the Middle East, as you well know, Rob. We changed our ministers, and they need to show they've done something. So what the US can help us with, US has several good programs that have been, again, part of it. The field epi training program that CDC runs, similar to what EIS here, all the disease detectives that you see in the US, I'm one of them. Helping us to establish field epi training program. We have one in Egypt, we have one in Iraq right now, very young, that I'm actively working with. Empower them, train more physicians that can do public health. That's one. Two, guidelines for hospitals in terms of preparedness and protecting ourselves. So if you take the example of Lebanon, we have very good hospitals, private hospitals, and even some government hospitals, but very few of them are equipped for such a pandemic and such a disease that's very contagious. What happens, they have a capacity for, let's say, 50 patients a day. When you overrun their capacity, it will go to the other hospitals in Lebanon that are not prepared, and then you will have infections for those physicians in these hospitals. But the way the system works in Lebanon, a doctor in the American University Hospital, well protected. If he or she goes to another hospital to perform a surgery that's not protected, he's going to get the infections over there. Or like what's happening with my colleague in Iraq, I don't want to do it because I'm afraid. So if the US can help us with epidemiology field epi training program, like we helped China and Korea, help us with a guidelines for emergency preparedness and syndromic surveillance, will help us with the second wave of another outbreak, which unfortunately in our region will happen, whether man-made or by nature. Thank you.
Very good. Excellent. Dr. Khalil, anything you'd like to see from the United States to help your country?
Yeah, you see, I quote first the statement made by Boris Johnson when he announced to the British people that no more austerity measures, which means that he knew already the lesson of a decade or two or three of austerity measure, how much has it negatively impacted the health services. In Egypt, a very sensitive area is as I mentioned, the allocated budget. And after the 2011 revolution, the 2014 constitution stipulated that the total government expenditure on health should not be less than 3% of the GDP to increase gradually till the international standards, let's say 6% of the average. And it increased to 2.2%. But unfortunately, between 2016 and 2019, there has been an agreement with the IMF that imposed severe austerity policies. So the budget allocated to health started to decrease. Even in the last budget of the fiscal year 2020 to 2021, while most of world countries are performing expendatory budgets, yet our budget is still largely restrictive and largely austerity. And the financial institutions still advise austerity policies. So we hope that international monetary institutions and United States stop its advice with austerity measures.
On austerity. Okay, thank you. And Dr. Al-Maliki, what, if anything, would you like to hear?
Well, I mean, sadly, when it comes to the virus, there is no model country. I mean, the US is not really a model to offer much, but at least two things. One is to help Iraq. I mean, Iraq is in partnership with Iraq under the strategic agreement in all sort of sectors. They may activate that to perhaps mitigate some economic difficulties through loans and grants in order to encourage the government to reimpose the curfew. Because the key we know is social distancing, mask, preventing gathering, the social restriction is the key. Without that, nothing really succeeds. And you have to give the people the incentive to do so by facilitating their economic problems or mitigating them. And the second, which is very, very critical, and the US can play a leadership role, not only for Iraq and the Middle East, but around the world, which is a propagation of a standard of care through the CDC and coordination with the WHO. These standard of care get renewed every week as research produce more and more conclusions. Iraq still depends on therapies that have been proven to be toxic, and this may actually contribute to more mortality. I don't know how this coordination can be. I'm working, and Dr. Mokdad, I will be happy to kind of talk to you after this. I'm working on a paper now to be conveyed to the commission that is working with the Prime Minister to at least tell them what the standard of care for COVID right now in our institutions, at least in the Ivy League hospitals, and what the recent development in research have found, and what agents are we treating our patients with. And I'm sort of surprised that that propagation of information is so slow, and there is a lag of 2 to 3 weeks, even more, for how we change our protocols, and the rest of the world is lagging. And that's probably a way, but I don't know the mechanism.
Well, information at least is free. And so getting information into the right place, right people in the right places should be the easy part of what at least we can provide to governments and medical professionals in this part of the world. Look, I want to thank all three of you, Dr. Ali Mokdad, Dr. Mohammed Hassan Khalil, Dr. Mohammed al-Maliki. Thank you for this fascinating, really in-depth discussion on the situation facing Egypt, Iraq, and across the Middle East. I'm grateful to you for your insights, and I'm grateful to everybody for watching and participating in today's program. Thank you from the Washington Institute. I'm Rob Satloff. Thank you, and have a good rest of the day.
Thank you.